Put
Sir,
the
sir.
recording button. Just a second. So, like lidocaine. Okay, forget about it. What is the mechanism of action of lidocaine? Yes, sir.
Works on the sodium channel.
Very good. So when sodium channels are blocked, does lidocaine effect from the outside of cells or inside of the cell?
Inside, from inside.
Okay, so which portion of lidocaine crosses the cell membrane? Ionized or unionized?
Unionized, sir.
Okay, and which portion block sodium channels?
Sir, I'm sorry, I can't answer. I don't know this, sir.
It is converted, by the way, to ionized. Okay, when it crosses the cell membrane, it is just like you if someone is fighting very aggressive, the guard will stop. But if someone is nice, he talks to the guard nicely, maybe the guard will allow to enter. Okay, so it hides its equipment, its ammunition while crossing the door, and as soon as it crosses the door, it again becomes wild. Okay, so you can remember like this: the unionized portion crosses the cell membrane, and actually it is the ionized portion which blocks. So which like part of or which state of sodium channel it blocks? Because this one I'm not exactly sure. If anyone knows about it, just speak out, please. It blocks the sodium channel in resting state or active state. There is, if anyone remember it, can recall it. Dr. Javed, you don't need to record it because the recording will be there in the YouTube. Okay. So you are trying to record it. You don't need to record it actually. The recording will be available. Okay. Okay, Azhar, do you understand my question?
Sir, you are right. Actually, there are three states of the receptor.
Mm-hmm.
So I'm trying to recall the which is in which state it takes.
Okay. Okay, I will just try to find out the answer. Because this is MCQ, I don't remember it because the topic which I want to discuss is not this one. In the meantime, if you find the answer, please let us know. Okay. So actually, the thing which from which we started, that lidocaine is there to blunt the stress response. Okay. So the point of view is that why, if we are using it as a bolus, okay, if we are using it as a bolus and we have like uh, this concept that, as you were saying, that it will blunt the stress response. Okay, so why can't we use it as an infusion? Okay, because whenever there is pain in the pain pathway, actually the actual place why pain occurs, it's a response to the injury. So whenever there is injury, there is a release of inflammatory mediators. Okay, so actually this is you can say protective mechanism, and actually it is important for the healing. Okay, but when this inflammatory mediators are released, there is a sensation of pain. So there are so many ways to control the pain. So one of them is, like, if you, because whenever there will be pain, there will be sympathetic stimulation. So when there will be sympathetic stimulation, there will be tachycardia, there will be blood pressure, and all the or the effects which occurs as a result. There will be release of uh, stress hormones, like there will be hyperglycemia, and all of these things will be towards the fire, fear, flight, the same towards the same side. So the number of medications which we use is that we just want to like blunt this response, that we don't want tachycardia, because if there is a diseased heart, or there are some there are like patient has, whenever there is tachycardia, there is increased oxygen requirement. So yeah, your purpose is to decrease this thing and keep, like, whenever there is a noise in the class and the teacher comes and thus keep the duster and put it on the table, knocks it very loudly, thak 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 thak, and there is silence. So actually, we just need something which creates this thak 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 and create silence. Okay. So that is the basic purpose that for which we are giving lidocaine as a bolus. Actually, the clear mechanism is not known, because if it is blocking the nerve channels, the things, this is related to action potential and everything. So this is not the clear mechanism for which we are giving. So you can say it is membrane stabilizing effect, because lidocaine we are giving for the initial management of sort of ventricular arrhythmias. Okay. uh, Premature. Am I audible? Is my voice clear? Azhar, can you hear me?
You you are audible, sir.
Okay. So I
Yes,
hope
we can hear you.
I'm sorry.
Please. Yes, we can hear you.
Okay, thank you. Thank you. So the same mechanism is there. Like our purpose is that we are just trying to modify the response. Okay. So the concept is the same. So it's being used in a number of surgeries, and the basic purpose is that we blunt the stress response, and we are doing the same principle, that when we are doing the laryngoscopy, there is a stress response, and we are by giving either topical lidocaine or giving IV lidocaine, we are blunting this stress response. So the same stress we are trying to do it, but in the form of infusion. Okay. So the exact, as you will find here, that the exact mechanism is not known. Is a, you see, just a second, please. Is an amide a type local anesthetic that exerts its pharmacological actions through the blocking of sodium channels in neural tissues, thereby interrupting neural transmission. This action is best demonstrated when the drug comes directly in contact or vicinity of neural tissue, as I was studying. The systemic effects of lidocaine are probably at or least partially related to this mechanism. The exact mechanism by which IV lidocaine provides systemic analgesia remains largely unknown. Okay, but they are still using it. So that was my question, Azhar, when you said that we use it to blunt the stress response. So actually, we exactly don't know the mechanism, but most probably it is as a membrane stabilizing effect, and it is just trying to blunt the response to the stress. Okay, so that is the main concept. And like systemic effects of lidocaine occurs predominantly in damaged and dysfunctional nerves, where it prevents depolarizing of neural membranes. There is also some suggestion that systemic lidocaine may also reduce or prevent the new proliferation of active sodium channels and block their spontaneous firing, especially in traumatized and scarred tissues. In acute, like this is will be the mechanism in the pain. So probably it is acting through it. So IV lidocaine demonstrates significant analgesic. What is hyperalgesia? They have written here anti-hyperalgesic. What is hyperalgesia, Azhar? And can you give an example of hyperalgesia? Yes, Azhar.
What I understand, the hyperalgesia means small nauseous when it does have a greater effect.
Yeah, it is a increased
Exaggerated.
response, exaggerated pain response. Okay, like if I'm
Yes.
touching, if I'm hitting with a finger, you are thinking that it is hitting like a hammer. Okay, so similarly,
That's
like can you give an example of hyperalgesia?
right. Can
So like
we
in herpes
patient
zoster,
experience?
shingles.
That is neuropathic pain, Zishan. Hyperalgesia as occurs with, for example, if you are giving a short-acting opioid, okay, like remifentanil. So if you stopped it, because it will be metabolized very quickly, so its effect will finish immediately, and there will be severe exaggerated pain in the patient. Okay. So that is actually opioid-induced hyperalgesia, and this occurs even even when you are using a lot of opioids. When you suddenly stop, then maybe there may be severe pain. So this is one of the very dangerous side effects of use of opioids. It is slightly different from tolerance and addiction. It is a slightly different concept. Okay. So for this same anti-hyperalgesic effect, actually not only lidocaine is being used, ketamine is also being used. Okay. And there was some discussion going on. I'm just, because unfortunately I'm not following, like I'm not able to uh, participate a lot in the WhatsApp group these days because of my busy routine. Like so, but I found someone discussing about ketamine in I. So actually, remember one thing: ketamine was being used is a multi-dimensional thing. So ketamine is being used for a number of purposes. But if you are using ketamine in the way we are discussing lidocaine, the similar there is another medication which is magnesium sulfate. Okay, so I am a strong like advocate and you can say representative of opioid sparing anesthesia, because I have tried to reduce drastically the use of opioids in my practice. And if I'm using opioid, I'm using the grandfather, that is morphine, not the tiny many opioids. So before I used to have a lot of remifentanil, but like I have seen that there are non-opioids which are much more superior than all these medications. So lidocaine is one of them. Similar is low dose ketamine. I can guarantee that low dose ketamine has no problems. Like you can use it in any patient and there will be a lot of advantages. You will be surprised that low dose ketamine also prevents delirium. Okay, because in coming days, maybe because I'm preparing a topic of opioid sparing anesthesia, so maybe I will be discussing magnesium sulfate, ketamine in following days. Okay, and eras again. um, I had last session which we did was on opioid sparing or opioid free anesthesia. So these are the things which are very important. Okay, so lidocaine has analgesic, anti-hyperalgesic, anti-inflammatory properties. It reduces, like it has a number of effects which are they are similarly, you see, ketamine also has effects on NMDA receptors. So similarly, it has also lidocaine also reduces sensitivity and activity of spinal cord, central sensitization. Because you can say this is all like there are four steps of the pain: transduction, transmission, modulation, and perception. So this is acting on the modulation. So it reduces the sensitivity and activity of spinal cord neurons, central sensitization which occurs, and then decreases NMDA receptor mediated post synaptic depolarization. Okay, so it is just like ketamine is also NMDA receptor antagonist. Other studies have additionally demonstrated a clinically relevant decrease in systemic inflammatory markers in patients receiving lidocaine perioperatively. Okay, so like if someone asks you, it has membrane stabilizing effect, so it is blunting the stress response, it is analgesic, it has some anti-hyperalgesic effect, and it is also anti-inflammatory. Okay, so how to use it? So first of all, before telling that, like lidocaine is metabolized in the liver. Okay, and all these medication, because even if you are giving in any place, ultimately uh, uh, any local anesthetic which we give is absorbed in the circulation. So other like, because you are at my hit list at the moment, can you tell me which places are there after IV? Which places has the highest of absorption? This is actually this question is also for only for you. After IV, which place is the most absorbent place for local anesthetics? Yes, Abhishek, you want to tell? Anyone, please? Zishan.
So intercostal block.
Okay, after that.
Second
Okay,
one I forgot.
okay. Yes, I think it is caudal.
Sir, I
No, sir,
suppose
I don't
caudal is
think it was
B.
caudal. It was something else, not caudal. I think.
Okay,
In the
Zishan,
books
just
it's stated BT ISEPs, blood, then tracheal,
tracheal,
and then intercostal. Then
and
intercostal,
then,
sir.
and
BT
then,
ISEPs is the mnemonic.
okay, and after that,
BTI intercostal, that's SEPS, CEPS, like that, sir. Let me search and I give you answer.
okay, okay. So this is actually sideway question. So how to use it? So as I was telling that lidocaine is being metabolized in the liver. Okay. So you have to be careful because whenever any medication which we give by any route, okay, it is ultimately absorbed in the blood as per its blood supply. Okay. As much will be the blood supply of the area, as much it will be. So ultimately what will happen that the blood levels will be there. So for lidocaine, it is I think more than 5 microgram per ml as it written here. Okay. So therapeutic level is around 2.5 to 3.5. And if it occurs more than 5, it will be the toxic. So you just have to make sure that if there is any problem in the liver, okay, and because in perioperative period, even for a surgery like 4 to 5 hours, okay, because what they did that lidocaine they started for colorectal surgeries, especially when they convert they like may start doing it in laparoscopic assisted colorectal surgeries, okay, like sigmoid dissection and colectomy and things like that. So in which the NCN is relatively smaller. So maybe for the first instance I used lidocaine around 6 7 years ago. Like when I was doing like I was at King Faisal, and there I saw for the first time people using lidocaine. They started at 1 to 2 milligram per kg at the start. They maybe start from 2, and according to the response, and then they as soon as the stress response, the surgical stimulus is decreased, they gradually decrease the rate, as they have written that they will start at 1 to 2 milligram per kg, as followed by 0.5 to 3 milligram per kg up to, and usually they change every what they I had written, it was written here, like they gradually increase by 0.5, okay, according to the response. Okay. So usually it is 1 to 2 milligram per kg per hour. And again, I told you that hepatic metabolism. So you have to be careful about it. If the liver is not functioning, though you will reduce the dose accordingly. And because in these studies, they have continued it even in post-operative period. I have never, of course, because we are not there in the post-operative period. ICU is not covered by anesthesia in Saudi Arabia. So I can never do this practice. But I have seen people doing it even there are some studies for post-operative, this one, chronic pain. In chronic pain patients, they have tried. So these are some of the extra points like context sensitive half time. So can anyone tell what is context sensitive half-life? Who will tell? What is context sensitive half-life? Shimail, Fatima, you are not there only for messaging. Speak out.
After infusion, sir.
Context sensitive half-life is when some drug is on infusion and then that drug eliminates through the body after some time,
Very good.
and it's
Like
different from that of half-life which is given by bolus.
because if you are giving by bolus, if you are continuing it for a long time, there will be different dynamics. Okay, because it will depend on the compartment models. Am I right?
Yes. That drug is absorbed in the fats of the patient, and then it dissolves out of the blood in the blood, and then it is eliminated. So it
Yes.
takes longer to be eliminated when it is given in infusion form, but in bolus form, it is eliminated early.
Because actually you can say that, maybe I will just rephrase what you are saying, that some medications, they are metabolized rapidly in the blood or in liver, for example.
Yes.
Some medications, their effect finish by redistribution. Can you give an example, Shemail? Any medication which we use very frequently, their effect finish by induction agents like propofol, thiopentone. Their effect does not, they did not have metabolism very fast. Their clinical effects finish by the redistribution. Okay. So when the redistribution occurs, then the clinical effect finish. So, but you are using, for example, same propofol in infusion, the effect, even if you stop, the effect will remain for more time, because now all the fat is being saturated. Similarly, maybe thiopentone is not suitable for infusion because it has terrible hangover. If you are using an infusion, patient will not wake up. So this is the concept, the same concept which we use. It is so okay. So lidocaine, uh, even after if you are using for 3 days infusion of lidocaine, it is 20 to 40 minutes, and there is no accumulation over time in a healthy individual. So this is, you can say, a safety margin, that if liver is functioning, nothing will happen. So these are two very beautiful babies of lidocaine, MEGX and GX. I don't want to pronunciate it. Monoethyl glycine xylidide. So it is just like some African babies. I'm sorry. Don't. If anyone from Africa, don't mind it. I think this is just like difficult name. Okay. I think there is no more difficult name than from Sri Lankan people. I found some Sri Lankan cricket people who have very difficult names. Okay. So, anyways, uh, MEGX has similar convulsant and antiarrhythmic properties as lidocaine. However, MEGX is rapidly metabolized by the liver to GX. MEGX also been shown to decrease the clearance of lidocaine. These are some extra points about its metabolites. GX has significant less activity than lidocaine, and it is both metabolized and excreted by kidneys. MEGX has been known to cause toxicity in patients with cardiac failure, and GX known to accumulate in patients with renal failure. This is some extra points, but you can say overall in normal patient, this will not occur, and liver will metabolize and kidney will excrete it. But if you have some certain condition, there may be some toxicity. Okay, so these were points about therapeutic levels. Okay, like usually 2.5 to 3.5 microgram per ml. And of free lidocaine include the dose, the rate of injection, acid-base status, hypercapnia, hypoxia, low plasma protein levels, and diminished hepatic or renal function. So these are the things which you should be knowing, that how much dose you are giving, how much rate of injection, if you are and then acid base status. Can anyone tell what will be the effect of acid base status? Anyone, please? It is related to the PKA. Okay.
PKA of the
PKA of the
drug.
drug.
Yes, PKA of the drug. So more free drug can be there. The more unionized portion may be there. Similarly, this hypercapnia and hypoxia, and then low plasma protein levels, because it is highly protein bound. It is one of the medications similar lidocaine, or also bupivacaine is even more protein bound. So the protein levels will affect its free drug. Okay. So these are the some points. Very rarely do patients actually have hypersensitivity idiosyncrasy. This can occur with anyone. or diminished tolerance to systemic lidocaine that is independent of above factors. Okay. So these are actually, most of the things are also true for a number of medications. This is not specific, this is general concept. So you can, by this reading this points, you can correlate with any medication. Usually a number of medications will have effect with this one, with reference to binding and also acid base status. Okay. In our experience, lidocaine toxicity almost always a result of iatrogenic error in dose, delivery, or infusion. They did not find any toxicity. I never found it. I tried not to exceed too much, but usually I never find it, because sometimes it is not, again, because a number of things I share, this is non-technical. Nobody, please don't try without infusion, with infusion pump. But what I do, that if I see that this at a fixed rate, this fluid will not finish within 15 to 20 minutes or half an hour at least. I can even if it is opened fast, it will not finish before half an hour. So I can put the dose which is safe to be given, like half milligram per kg. Like if the weight is 60 kg, I put 30 to 40 milligram in 500 ml bag and make it slowly. Label it and make it slowly. And as according to the results, the reduction in blood pressure and heart rate, I can say that I can even reduce the rate accordingly. This is what I do when I don't want to use it through syringe pump. Now, technically, you should not use it without syringe pump. Okay, but this is a slang way of using these medications. But of course, you cannot officially use it in that way. Okay. So, okay. So, and then of course, you should be knowing what symptoms can occur, like arrhythmias can occur, because in awake patient, you can find with circumneural numbness and lightheadedness and visual problems and twitching, and then leading to coma and respiratory or cardiovascular. But in sleep patient, maybe only like cardiac toxicity will be visible. Maybe if you are using BIS, maybe there will be some changes in the BIS. So they will tell here the same thing. They will tell that what happens in the toxicity, a negative inotropy gradient problem with conduction problems, or after myocardial infarction, effects on conduction. Okay, sinus arrest. These effects are potentiated by acidosis, hypercapnia. Same thing they are telling. So okay. Evaluating the evidence. So actually there was a this Ottawa, I think this is some Canadian hospital which they have devised a protocol preparation, the how to use it, administration in a clinical area where continuous cardiac monitoring, blood pressure, oximetry, resuscitative equipment are there. Okay. Assess clinical signs, vital signs, and pain score at rest and with activity. This is actually more so for use in other setting than perioperative period. But this is the same concept is there, that you will prepare, you will monitor the patient, and then there is a bolus, and then you will give an infusion. So I will share this article. You can have a look on it. The basic concept is what I have already told you. And it reduce the requirement of opioids. Okay. And even sometimes like I even don't give opioids at all throughout the period, with use of either lidocaine, with ketamine, with the dexmedetomidine. I use a combination of these medications, and actually sometimes now I am just trying to reduce or even avoid opioids at all, and I'm doing it successfully. I did gradually reduce the dose of opioids, and actually now I'm not giving opioids at all. Okay, it looks weird, but of course, at least in intraoperative period, we can do it. And post-operative, of course, if you are not managing the post-operative periods yourself, maybe it will be difficult for you to, and it needs acceptability with the patient and acceptability with the PACU staff, ICU staff, and surgeons, because it is very difficult. Recently, there is a growing trend towards this ERAS. Okay. So the ERAS protocol, we will discuss ERAS. I have discussed before as well, and maybe we can repeat it. I will share the link for ERAS as well, because all of these things are interrelated. Because when we are using lidocaine, the requirement of opioids is significantly reduced. So there are so many side effects which we are avoiding. And then we are following the whole ERAS protocol. They are using less bowel preparation. They are avoiding too much preoperative fasting. They are giving good fluid boluses. They are trying to avoid the drains. There are so many things which they are doing. And overall, the result is better patient outcome. Okay. So, that's what actually I told you, that they compared IV lidocaine with epidural analgesia for laparoscopic colonic resections. Okay. Reported no difference in post-operative pain intensity, early mobilization, dietary intake, duration of hospital stay, and post-operative complication between the groups. Confirms that even in well-established protocols for I can ensure the same ERAS outcomes as continuous epidural infusion. So you will say, why not to use epidural? Epidural is much more invasive. You are entering a terrible area, actually. So there is no epidurals now in these patients. Even today, I was doing a laparoscopic resection, and I did not use epidural at all. Okay, that was a different case, but I'm just telling you that they are not, they have totally reduced, because in our part of world, epidural is still worshipped much more than it should be. Okay. So lidocaine may be useful as an adjunct to treat postoperative ileus. Okay. Because the problem with opioids is ileus, and it is augmented if there is aggressive bowel preparation, hypokalemia, less fluid. You are afraid to give fluid, and the patient is hypovolemic, and electrolyte imbalance occur, and then you are exaggerating. There will be more ileus, there will be more postoperative pain, more visceral pain component if there is ileus. Okay. So not only the patient is able to mobilize, hospital stay will be increased. So you are inviting too many problems, and or you can say that you can get a lot of benefits if you are not using opioids and you are using these medications. One of them is lidocaine. Okay. So opioid analgesic requirements may have indirect effect on the gut motility by decreasing pain, opioid analgesic requirements, and sympathetic block. A remarkable case series reports IV lidocaine in the management of ileus secondary to spinal cord injury. And in patients with ileus after a serious spinal cord injury refractory to conventional medical management, 5 out of this is they are quoting some other example, but the concept is the same, that lidocaine may have a more direct effect on the gut than previously considered. It is our opinion that lidocaine may prove to be the drug of choice in management of postoperative ileus, although further controlled studies are necessary to confirm this. Okay. So the role of IV lidocaine has been evaluated in other surgical. They are just giving the examples of the different studies. Okay. But yeah, and actually I have used it in almost all surgeries. Myself personally, I have used it, and not only in this colorectal surgeries, which they are telling. You see hip arthroplasties, hysterectomies, what example they are given. Post-amputation stump pain and prevention of persistent pain after breast surgery continue to provide encouraging results. Okay, so they are doing this article even is, I think, 2 year. This is quite old article. You see, there are so much development after that. I did not find a recent article, but was the time when I actually used it first. So, any comments? Any things about this concept? Because majority people, I'm sure, will have a lot of arguments on it. Any comments, please? So they just they have made a protocol, patient selection, benefit. You have to, and then regional anesthesia technique where they are using IV lidocaine is contraindicated when other regional anesthesia techniques are currently used. Of course, you cannot do two things, that you have given epidural plexus and then you are putting also, so there will be toxicity because the dose will be too much. Okay. And you have to maybe only be ordered by the anesthetist. All nurses on where this treatment modality to be implemented should be educated regarding the policy and procedures. They are just telling the procedure, but actually that is the reason that post-operatively we are not able to implement it, because there are so many hurdles. Till the time it is, I don't think so. It is easy to use in post-operative period. Okay. So that's what I wanted to discuss. There is silence. So what does it mean? No comments, or anyone wants to speak out, please, before we finish? No comments? Zishan?
Aslan
Yes.
sir,
Walaikum
sir,
assalam.
I
Yes,
joined
Ahmed.
a bit late.
Yes.
Sir, I wanna ask what is about loading dose, because I am currently using this Lidocaine IV infusion during spine surgeries and laparoscopic cholecystectomy or other laparoscopic procedures, and
Yes.
sometimes it is giving me a wonderful result that in 3 spine surgeries, even 2 patients were giving me feedback that they didn't felt any pain until the discharge after
Yes.
36 hours.
So you see, this is the 1 to 2
But
milligram, the same thing. You see, this is just to remember that 1 to 2 milligram per kg, you give it at the induction. So same dose per hour. So you can give 1 milligram per kg per hour. And of course, I think
okay,
it is remember one thing, it is very easy to give extra dose if you have given a lesser dose. But if you give it, you cannot pull it out from the blood. Okay. So it is better always to give from
okay.
less, and then you can increase, augment it. Okay.
Sir, one other thing is that what I have noticed that maybe you people or other people might have noticed this too, that I think there is a difference between surgical procedures. Like
Of
there is
course.
no same effect in all surgeries. During spine surgery, my feedback of my patient is wonderful. But as
Mhm.
compared laparoscopic cholecystectomy that my surgeon here is doing in 20 minutes or 30 minutes, there the fact these patients with laparoscopy, they are not as satisfied as the patients with the spine surgery.
Of course, I tell you that it will not be not only with reference to the site of the surgery, patient population. Different patients have different pain threshold. Okay, so this may be the reason.
Okay. Thank you, sir. Thank you.
Okay, so anyways, thanks a lot, all of you, for your presence, and inshallah, we will come with different topic, inshallah. Assalamu alaikum.